thank you, everybody. We're now going to have, before we begin our program, we're going to have our tidbit from Jeff Hagen.
For those of you who haven't been here for a couple of months, we've started a new program called a tidbit, which is a couple of minutes, and this is a continuation from last month, which is traveling down the Post Road with old and semi-old places, because the Post Road was the main drag from early times until the present. And we got as far as, we got past Mamaroneck Motel. We started with the Royal Inn on the Nershell line, which burned down. We went through a number of hotels, and we got to a point where we have, you remember Bernadette Castro and Castro convertibles on the Post Road.
Right.
And that place was quite a famous place. That was the Red Lion Inn, a very historical inn until they tore it down to put up a box store. And in fact, during the Depression, it was operated as a nightclub. Across the street is one that's still, probably the only one that's still standing, and that's the Post Lodge, which is the VFW. And that was also one of the historical places along the Post Road. Moving up from Bernadette's place, relatively new, but one that those of us who have been around for a while, long for, and that's Cook's. That's not historical, but it was a great place because we could go there and get breakfast and sit around, and high school teachers would do their homework, check homework, and it was a great place, and we still all long for Cook's. And if you travel up a bit,
with the video games.
and the video games, yes, so you could put the kids in the back, and and then if you travel up a little bit where McDonald's is now, does anybody know what was there before McDonald's?
Custard stand, was it?
Pardon?
Was it a custard stand?
You're half right. There was a custard stand or a milkshake stand, but there was a miniature golf. It was a great miniature golf place in the parking lot of McDonald's. And then if you travel up a bit, we come to the Mamaroneck Motel, which a lot of people don't even know is there, across from the Post Road building of the high school. And it's actually a very well-run, family-run motel. And a lot of people who stay there are people who will come up here for long periods of time to work, construction engineers and that sort of thing. I was sitting next to Norm Rosenblum last month, and he said that his mother told him that there was where the Orient Apartments are across from the high school, that there was a place called the Palace Hotel. Now this is a new one on me. He says his mother told him it was a Palace Hotel, and it was known as a house of ill repute.
In America?
I don't know if that's really true, but I can't dispute Norm because it'll take a half an hour for him. And then traveling up the road, there was a great eatery place, which was the Washington Arms, and which is now the Montessori School, and actually quite well maintained by them. From the outside, it looks just like it did many years ago. And around the side on Orient Avenue is a rock with the face, natural face of Washington, which is why it's called Washington Arms. So we travel up the Post Road a little bit, and we come to the Toll House, which is undergoing yet another transformation. I don't know what it's going to be, but at least it's not a car wash, which is what was proposed. Then there was a very famous place where the Continental View condominiums, and that was, can anybody know that one? That was the famous Lawrence Inn, and then it stood there for a long time. It became, during my childhood, Tommy Chen's. I don't know if anybody remembers that, but it was a very, Lawrence Inn was probably the most famous place along the Post Road between Nershell and Rye. Then there's the that's not Mamaroneck Motel, it's Vincent's Motel, which is still there. And there used to be a place where the crab shanty, which underwent a lot of places, and I can remember, I don't know whether it was in the 70s, but it was a disco, and it was quite a concern, particularly to those in Rye, who looked down upon the disco being in Mamaroneck. Anyhow, that's my tidbit for today. On to that. If anybody wants one for next month, they're welcome to have the microphone. Just email me at jeff@meganfirm.com, and otherwise I'll come up with another one.
Thank you very much. And now I'm going to turn the program over to Judy Dubroff, who's going to introduce our speaker.
Okay. Thanks, Elaine. Thanks, Steph. That was great. We are very pleased today to have Mark Panay as our speaker. Today's program is going to focus on the recent healthcare reform legislation, the Affordable Care Act, or AKA Obamacare. And Mark Panay is the director of the Metro New York Healthcare for All campaign, a New York City-wide coalition of community groups and labor unions founded in 1993 that advocates for fundamental healthcare reform. He's also a member of the steering committee of Healthcare for All New York, a consortium of groups across New York State working for healthcare reform in New York. He's part of the Westchester-Putnam Access to Healthcare Coalition, so he's aware of many of the issues facing Westchester residents. And he's also presently part of the Greater New York Regional Advisory Committee for the New York State Healthcare Benefits Exchange. And a lot of what Mark's going to talk about this morning are the exchanges. So without further ado,
Good morning, everybody. How are y'all doing? So I'm going to try in about 20 minutes or so to kind of give you ACA 101, which is really not possible given the length and the complexity of the law itself, but I'll give it my best shot. You should all have an outline, one-page outline, 2 sides of a page of topics that I'll kind of run through quickly. If you don't have one, raise your hand, we can get you a copy. This will just be an overview, and then we can get into some of the details during the question and answer period, if that's okay. I guess I'd like to start out by reminding us all kind of why this healthcare reform law came about in the first place. And that was because we had a healthcare system that was imploding from within, and something had to be done about it. And sort of the political moment had arrived as an opportunity with the coming of a new administration and a Congress that was favorably disposed to craft and pass such legislation in 2009 and spilled over into 2010. When you look at American history, and it really is a very historic piece of legislation, it's the most historic piece of social legislation in about 40 years that has come out of the Congress. It's affecting 1/7 of our economy, the healthcare system, so it's not an insignificant piece of legislation, and it's going to take time to roll up various pieces. And like with any piece of major social legislation that's enacted, it's a work in progress. It's a step forward. We saw with just recalling the Social Security program that was created in the 1930s, we didn't really see it come to full fruition as we know it today until the early 1950s. And similarly for the Medicare and Medicaid programs that were enacted in the 1960s. They didn't really come to us, well, for instance, it was only in the last decade that we added a prescription drug benefit to the Medicare program. So I think that you kind of have to look at this piece of legislation in that line of work. Senator Tom Harkin, who's now chair of the Senate Health, Education, Labor, and Pensions Committee, calls it a starter home. And we can build on it as we go, and hopefully it will become a mansion over the years. But that's kind of a good way to think about it. But it is, so it's this is the culmination of a century-long effort to enact national health care policy in America, broadly speaking, to all members of our society. The first presidential candidate to talk about national health care in some way, shape, or fashion was Teddy Roosevelt in the 1912 election. Then we had a somewhat go of it during the New Deal period It was initially part of President Roosevelt's New Deal package, but was jettisoned in order to allow the rest of the package to go through. Then we had a discussion after the war with President Truman in 1948, 49, and 50, tried to put forward proposals for national health care. That didn't happen. And then we built up a head of steam again around that conversation, and what came out of that in the 1960s was the creation of the Medicare and the Medicaid programs. Medicare, a national program that covers older Americans and now people with long-term disabilities, and the Medicaid program, which originally started out primarily as a program for low-income people, but has evolved over the years now to cover many children, many pregnant women, lots of older Americans needing long-term care services. And it's really, in that context, very much a program for the middle class. It's our default long-term care program that we have in this country for people who need long-term care services, either in institutional settings like a nursing home or within the community. So it's a step forward. We then had an effort at healthcare reform in the early 1990s when President Clinton came into office. That unfortunately didn't come to fruition, but what did come out of it a couple of years later was the creation of the state child health insurance program, which was modeled on New York's Child Health Plus program, which we began in the early 90s, and became a national model. And this is sort of a theme that I'll kind of keep bringing up during my remarks, how much New York has been a leader state all along, and much of what we have already done in New York is now embodied in the Affordable Care Act and is going national. So I think we should feel a sense of pride about that, and remind ourselves of that we want to continue that tradition of leading forward. We want to, by example, show that this is indeed a starter home, and we can start putting some new wings and floors on it pretty quickly if we're good about it. And there are other states that are thinking about doing the same thing. Our neighbors in Vermont next door are really looking about how they can use the framework of the Affordable Care Act to move to a truly universal health care program. Because being a starter home, the Affordable Care Act only goes so far, but at any rate. So it's a major step forward, and I think the reason this time that we got national health care legislation through after a century of struggle was that in previous efforts at this, remaining with the status quo was always sort of everybody's second best option if they couldn't get what they wanted. But this time around it was clear that the status quo was collapsing and we had to do something. So the conversation was not really whether we were going to have healthcare reform legislation enacted. We were going to have something enacted. The only question is what was going to be in the legislation and who was going to determine what was going to be in the legislation and what that looked like. And that's what the struggle, the legislative process and that struggle was about in 2009, 2010. And we advocates tried as best we could to project the public's interest into the conversation and discussion and debate. Because there being this 1/7 of the economy, there are many vested stakeholders that have a real interest in what came out of the process, and they obviously have their role to play, but we wanted to make sure that the public's interest was at the table also. And it wasn't just about sort of rearranging the chairs amongst the usual suspects. So, depending on how the law gets fully enacted eventually here in New York, we have about currently 2.7 million New Yorkers that don't have health insurance. And if we do it right and robustly here in New York, potentially up to 2 million of those New Yorkers can get some sort of coverage under this law. So that's a really good opportunity for us. And the important thing to understand about the Affordable Care Act is that it is a platform for states to build on and use. It's a floor, not a ceiling. And states have an enormous amount of responsibility and some opportunities, if they play their cards right, to really make some steps forward. It really is kind of a federalist law in the sense that it's a partnership between the states and the federal government. The federal government sort of sets the overall framework and the ground rules and provides a lot of money to states for this, that, and the other thing. but it's really up to the states to carry the ball forward. And the good news is that New York so far is doing a pretty good job at fulfilling their responsibilities and so forth. So, what is this law? Basically, I break it down into sort of, there's three parts of this law. There's a bunch of stuff around insurance coverage, and that got a lot of attention during the debate process and subsequently, and rightfully so, because I think that's something of concern to a lot of people, all of us. Healthcare is an extremely personal issue. I think that's a good way to think about it politically. It's not just an abstract concept for people. The second thing that it does is it does a lot of things around changing the healthcare delivery system in a way to improve quality, improve efficiency, control cost growth, and expand access to care and services. So that's kind of was much more sort of an insider conversation, an inside baseball that kind of happened as the law was crafted. It didn't get as much media attention as the coverage things. And then there was the third aspect of the law, and that concerns various financing related provisions that pay for the coverage expansions and pay for some of the reforms to the delivery system. So if you kind of think of it that way: coverage, delivery system reform, financing. In terms of the insurance coverage provisions, what Congress and the President decided to do when they crafted this law was to build on and beef up the current ways that we provide health insurance coverage here in America. It's sort of the three-legged stool. There's the employer-based system, which is how many Americans get their health insurance coverage. About 60% of all Americans, it's been dropping, but it's now about 60%, maybe a little above that, get their coverage through some employer coverage, either for yourself or a spouse or a parent or whatever. You get your coverage that way. The second way, of course, is through public programs like Medicare, Medicaid, the Child Health Insurance Program, and so forth. And then the third way is sort of going into the private market on your own if you don't have access to either employer coverage or through a public program. So they kind of built on those three ways that we provide coverage and beefed them up. In the private insurance market, they began to regulate the industry much more aggressively and provided new consumer protections. Now again, we've had a lot of that stuff in New York for quite some time now. So for instance, insurers starting in 2014, a lot of the coverage stuff really kicks in January 1st of 2014. Insurers won't be able to discriminate against you based on your health history. Well, that's a law we've had in New York for 20 years now, so it's not an issue for us. They can't charge you more based on your health history. They can't yank your policy from you when you start filing a lot of claims. The government has to sign off on rate increases that insurers propose every year, and if they think it's too high, they roll it back. So all this kind of stuff that other states are now going to be experiencing, we've had in law in New York for quite some time as a consumer protection. Then in terms, we're creating this new entity called a health insurance exchange, which kind of sounds strange language, but it's essentially, they're organizing a marketplace for individuals, families, and small businesses to go and get coverage if they need it. And it pools everybody together, offers standardized benefits and standard policies, bulk purchase bargains with insurers, and so forth. So New York is in the process of creating this new health benefits exchange. And as Judy mentioned, there are 5 regional advisory committees around the state set up to advise state officials on the process of doing that, and I'm one of the members of the Greater New York City one, which includes the northern suburbs up here, in addition to New York City. So that's underway, and it will be going live to begin enrolling people in coverage, offering coverage programs, and enrolling people as of October 1st this fall, and the coverage will begin on January 1st. The state is preparing to do a major public relations and outreach and enrollment campaign beginning in the summer. So you'll probably start seeing things on television, hearing things on radio, seeing ads in newspapers, stuff on social media online to get folks ready for this sort of thing. And those of you who work in social service agencies that people turn to for information about healthcare, it's not unlikely that you'll start having people ringing on your phone and knocking on your door saying, help, what do I do, how do I understand this? The good news is that as part of setting up this exchange, there's money available to states from the federal government to create what's called navigators and in-person assisters to help people understand their options and get enrolled in programs. So again, this exchange will be an entity that will be available to people who don't have access to other forms of coverage, either employer coverage or through a public program. So it'll be individuals, families, and small businesses, or small groups, I guess I should say, because it includes nonprofits, are groups of 50 or less employees. And starting in 2016, that category will expand to 100 or less employees. So that's that. And then on the insurance and private insurance market, and you've probably heard there's been a lot of ballyhoo about this in recent years, the so-called individual mandate that you have to carry coverage. It's much less than it's cracked up to be in that because most of us will retain our employer coverage and others will be able to continue to access public programs, the number of people that will actually be subject to the mandate is quite small. I think they're estimating less than 10% of people will actually face this situation of having to purchase coverage on their own if they need to. And there are some exemptions from the mandate for a number of reasons, most notably of which is if you can demonstrate that it's unaffordable to your family, which I believe is, or if it's more than 9.5% of your family's income to buy the coverage, then you get what's called an affordability exemption. You don't have to carry the coverage. You won't pay a tax penalty, but you'll still be uninsured. That's kind of how that will work. And what's really interesting when we look at this law was very much modeled on a piece of legislation that was enacted in Massachusetts in 2006. And what their experience has shown is that both small groups and individuals and families really have picked up coverage as a result of this mandate. It's really been an incentive for them to do it. They've got their uninsurance rate down to now about 3 or 4%, which is quite dramatic. You really can't go too much lower than that. There's always a lot of people, for whatever reason, that are cycling in and out of coverage. And so you could probably get that down to maybe 2% if you really worked at it. But you're always going to have some people, for whatever reason, that are not going to be in the system. So those are kind of the changes on the private market side. On the employer-based side, I want to put to rest something that's kind of out there. There is no requirement that employers provide coverage to their employees. It was something that we advocates tried to get into the law but didn't succeed. But there are incentives and disincentives for employers to provide coverage. For employers that have 200 or more employees, they must sign up their employees in a program. The reality is that once you get much above 100 employees, most employers provide coverage at that point. The unemployment crisis, or the uninsurance crisis for employers, is really in the smaller group side of things. So that's that. For employers above 50 employees, they have a disincentive to not provide coverage. And I'll tease that out a little bit, because it's sort of the double negative there. If they decide to not provide coverage to an employee, and the employee goes into the exchange and gets coverage, and qualifies for a subsidy in the exchange, and I should pause for a moment, I neglected to mention this earlier. Individuals and families who go into the exchange to get coverage, if their family income is under 400% of the federal poverty level, which is currently probably about $90,000 a year for a family of 4, you'll be able to access sliding scale subsidies to help you purchase the coverage based on your income. The lower your income, the bigger the subsidy. And you also have a sliding scale out-of-pocket annual cost cap. So at a certain point, if you have a serious illness or injury, your deductibles and co-payments max out. And again, that's up to 400% of the poverty level too. So back over now to, I'll unpause myself on the employer side of things. If I run a company and I decide not to provide coverage and one of my employees goes to the exchange and accesses a subsidy, then I pay a tax penalty to reimburse the government for what they're laying out for my worker. So that's the disincentive to not provide coverage. For small groups 50 or less, there's a tax incentive to provide coverage, and that is that you get a tax credit up to 50% that you can take on providing coverage for your employers. And you go into the exchange to access the tax credit for the employees that you're providing coverage for. So that's kind of how that all works. And then there's some new special programs that have come online through employer programs that help address population groups that have higher than normal rates of uninsurance. Most common you may be familiar with is young adults under the age of 26. They can now stay on their parents' plan. Up to now, they've had the highest rate of uninsurance when you look at age cohorts, because they primarily work in entry-level jobs that oftentimes don't provide health benefits, or if they do, it's sort of lower wage. Oftentimes the employee can't afford to pick up the coverage that the employer may be offering. So this is the incentive to get that. And millions of young adults are on their parents' plans. The uninsurance rate has dramatically dropped for adults now. And again, this is modeled on something that New York and other states did back about 3 years ago. We have a law in New York that young adults can stay on their parents' policy up to age 29. So the feds didn't go quite as far, but we have that option available here in New York. And the other special program that came online was for the other age group that had the second highest rate of uninsurance, and that's what we call near retirees, age 55 to 65. They may be retiring early, or whatever reason, but they're not yet able to access the Medicare program because you have to be 65 to do that. So there's this incentive provided to employers to provide retiree coverage to those under the age of 65. And a number of employers have picked up that option. There's funds available from the federal government to do that. So that's the employer side of things. Now moving to public insurance programs. Talk a little bit about what happens under those. First, I want to put to rest the so-called big lie that's been floating around out there. And that is, there are no cuts to Medicare benefits under this program. In fact, there are enhancements to Medicare benefits, particularly dramatically helping people on Medicare with their prescription drug costs. The infamous so-called coverage gap donut hole is gradually closing. Now people who reach the donut hole and their drug expenses get up to a 50% discount on brand name drugs, and I think it's now up to about 9% discount on their generic drugs. So that's one big thing. People on Medicare are now getting free preventive benefits available to them, preventive services and care, and the government is very broadly defining what prevention means. It covers a wide variety of services and procedures, and also those what's preventive is tailored specifically to you. So for instance, if you have a diagnosis of type 2 diabetes, your preventive services may look very different and meet your needs in that condition as someone who might be diagnosed with, say, breast cancer. So it's very much tailored to what your conditions are. And then so that's the Medicare program kind of in a nutshell. And Medicaid, we're seeing a dramatic expansion of the Medicaid program possible. The law itself allows states to increase their Medicaid programs up to 133% of the federal poverty level, which is about $14,000, $15,000 per year annual income for an individual. New York, again, we're a leader state. We're already up to that in many cases and beyond that in some cases. Right now, we provide Medicaid coverage to individuals up to 100% of the federal poverty level, to parents up to 150% of the federal poverty level, to pregnant women up to 200% of the federal poverty level, and to children up to 400% of the poverty level. So we have a very robust Medicaid program already underway in New York. And so we're not going to see much of a change in our Medicaid program here in New York. We're going to see a few more people get some coverage through it, which is a good thing. But what we are also going to see is that we're going to see the federal government put a lot more Medicaid money into New York's program. Because right now we've been paying for those higher than what's required level. We pay for that a lot with our own state dollars. Now the federal government is going to be saying, here's the money to help pay for these people. So we're going to see dramatic savings in the state budget for the Medicaid program. And because New York runs its Medicaid program as a partnership between the state and the counties, that should actually relieve the counties to a significant degree of the cost of the Medicaid program. That, of course, will take some time to try to trickle down and trickle through, but at the very least there will be less upward pressure on county budgets for Medicaid. And then we have this option available to states, something called a basic health plan, which will essentially allow us to expand our Medicaid program even higher if we want to do it, up to 200% of the federal poverty level. New York's done some studies looking at what this would mean for New York if we were to do it. Again, it actually saves the state a significant amount of money. Everyone is favorably disposed to doing this kind of approach. We're waiting for the regulations and guidance to come out for the federal government. It's looking at this point like we probably won't be able to offer a basic health plan starting in 2014, which is what we had hoped when everything sort of starts to happen, the new Medicaid expansion happens, the exchange comes online and so forth. But we'll probably, according to some recent information out from the federal government last week, be able to start offering a basic health plan in 2015. So we'll be sort of stepping toward that as we go. We already have something that looks like a basic health plan in New York now called Family Health Plus, which is for people above the Medicaid level. So essentially what we'd be doing is expanding our Family Health Plus program up to 200% of the federal poverty level. And so I think that's probably what we'll be doing in the next year or two. I was up in Albany yesterday talking to people about that sort of thing. Okay, flipping over to the back side of your outline, and now I'll speed things up a little bit because I wanted to kind of go through the cover stuff because I know that's what is most interesting to people. You can ignore the top bullet on the page. This is an outline that's a little out of date. This program for a voluntary long-term care insurance program actually has not proved workable according to the federal government, and during the fiscal cliff legislation that they enacted in early January, they actually zeroed out the funding for this program and instead have set up a commission to look at what we need to do about long-term care in America. And I think that's sort of likely to be the next big healthcare topic that bubbles up nationally a few years down the line once we've digested the Affordable Care Act and get that all in place. Because we really do have, particularly with the aging of the baby boom population, of which I'm a proud member, is that we're going to have a serious need for long-term care services much beyond what we have now, and we're going to have to address that situation. So that's kind of the coverage aspect of things. Now in terms of the delivery system stuff, I'm much less of an expert on these things, and it's, as I was saying earlier, it's much more of a kind of inside baseball conversation, but I'll sort of highlight what aspects, some aspects of what the law does. in terms of reforming the delivery system. Expanded access to services. The big component here is that over the first 5 years of the law, starting in 2010 actually, the government is doubling the amount of funding it's providing to establish and operate community health centers across the country. So that's a really good thing to do. It's a way we can provide a lot more primary care to people in our country. When you look at the American healthcare delivery system versus other countries, we have a system that's way overbalanced toward acute and institutional care, and we need to really reorient it toward primary and preventive care. And this is one thing that is marbled through this entire law on the delivery system aspect of it, is that there's incentives and funding provided throughout it to really shift the whole healthcare system toward primary, preventive, community-based, ambulatory care services to get us and keep us healthy so that we need those acute and institutional services less. That's not to say that hospitals are going to go away or nursing homes are going to go away. We obviously have a need for them. But we have an over-reliance on them, and we wait now till people get really sick before we intervene to provide services, and we can't afford to do that really in the longer term. It's really as much about saving money as providing better quality care. Plus, people want to get the primary and preventive care. The public opinion research shows that Americans really value this. They think that it's a really important aspect of the law to move toward primary and preventive care, so that's what we're doing. There are initiatives to improve quality in the Affordable Health Care Act, particularly by building these large networks where we're going to start integrating different kinds of providers, primary care providers with institutional providers, with long-term care providers, with community-based providers and so forth, so that they form a broad network of services so that you can be assured that everything is kind of integrated together. There are workforce development initiatives, obviously, under this law, according to the projections of the currently roughly 50 million Americans that don't have health insurance. 30 million or more are going to get coverage either through Medicaid or through these exchanges. There's going to be a significant increased demand for healthcare services. That's what happened in Massachusetts the first 2 years their law was in effect. There was a huge increase in demand for primary care services, and they didn't have the capacity. So that's part of the reason why we're expanding a lot of the community health centers, building new ones, expanding networks. In fact, I think here in the Westchester region, the Open Door Family Medical Centers have been one of the ones that have been really expanding their capacities through the affordable care funding available through the Affordable Care Act. So there's incentives in there to train new doctors and nurses, nurse practitioners, and physician's assistants and so forth to beef up the capacity, and that's already underway. There are public health initiatives which help us address some of the social and economic determinants of health status for people. Because we know that when we look at the spectrum of healthcare is really kind of over here. But if we're wise in how we spend our health dollars, for every dollar spent on public health, we save $9 on the health care end of things. So it's really smart for us to be investing in public health initiatives, and there are things to do that. There are disparities initiatives in here because we know from the research that based on various demographic factors such as race, ethnicity, age, gender, sexual orientation, disability status, and so forth, you can get the shorter end of the stick in the healthcare system. There are initiatives in there promoting wellness wellness programs, particularly for employers, to offer wellness programs as part of their healthcare benefits packages. And there's reforms in here which is called reimbursement reforms. It's really going to reorient our healthcare system in a fundamental way, moving away from piecemeal fee-for-service so that you literally, in some cases, charge for every aspirin tablet if you're in the hospital, to where they provide payment for what's called an episode of care for treatment of a of a full illness over the course of both perhaps hospitalization as well as outpatient treatment afterwards until there's full recovery. And there's an interesting article on the front page of the New York Times today about looking at how healthcare cost growth has really moderated quite dramatically in the last 3 or 4 years, unexpectedly. And people are trying to figure out why is this happening. And one of the things they're pointing to is that we're moving toward these more integrated delivery systems that I was describing and moving toward payments for episodes of care. So we're already beginning to see some benefits of that, which was really, as the article correctly points out, underway before this law was enacted, but this law is really accelerating the process because of the incentives provided to it. So those are the delivery system things. Quickly on the financing provisions, there's lots of, because of the delivery system reform provisions that I just quickly ticked down, there's a lot of savings that are going to hopefully be generated or projected to be generated, let me put it that way, by the Congressional Budget Office when they analyzed this law as it was being crafted. There are lots of cost savings in it, and it's going to be cost savings to both public programs like Medicare and Medicaid, as well as throughout our healthcare system. So it's going to moderate cost growth for employer-provided coverage. It's going to moderate cost growth in the private insurance market. And so these are many good things that are going to happen. And again, this is compared to the baseline of what would have happened if no law had been enacted. It's always relative, so you kind of have to think of it in that fashion. And this is where the big bugaboo comes, where certain people have been talking about, there's $500 billion cuts in the Medicare program. Oh, isn't this horrible? Well, let's step back a little bit. Again, there are no cuts in the Medicare program. There are savings that are generated in the Medicaid program through a lot of these delivery system reforms, and there's savings over a 10-year period, because that's how Congress budgets major pieces of legislation. So that $500 billion, $500 billion is over a 10-year period. So it's really about $50 billion a year, which is not that much money when you look at the overall cost of the Medicare program. And given some of the changes that are happening in the Medicare program to make it more efficient and improve quality there, that's sort of where that figure comes from when people talk about $500 billion. It's really about cost savings over a 10-year period. It's not an upfront cut, which is kind of how some people have been mischaracterizing it. And then there's some new taxes that came online to help fund this expansions of coverage. There's higher Medicare payroll tax for people who, the top 2% of taxpayers. There's an excise tax on the excess value, thank you, for people who have sort of gold Cadillac plans. And that starts in 2018, you'll pay that. And then there's a windfall profits tax on insurance companies, drug companies, medical equipment manufacturers, and so forth, because they're getting a lot of new customers out of this deal, with 30 million plus people getting new coverage. So it's a way to kind of claw a little bit of that money back. So what's next in terms of moving forward? Obviously, events like this, I'm more than happy if you'd like me to come. I have colleagues that can come and talk. We have to do a lot of public education about the Affordable Care Act. There's a lot of, it's a very complicated, complex law. There's lots of things to understand about it. There's a lot of confusion out there, ignorance, justifiably. There's a lot of misinformation, in some cases outright lies that are being told about the Affordable Care Act. So public education is really a critical component. And that's going to be especially important in the next 6 to 9 months, particularly as the state rolls out this public education campaign about the exchange. People are going to be aware that there's new coverage options available. They're not going to understand them. As I was saying to you a bit earlier, people are going to be turning to you and your agencies for advice and assistance and help. What do I do? And it's going to be a lot of one-on-one hand-holding, and you're not going to sit down and figure this out in one counseling session with a person. people are going to want to go through, understand their options, and say, I want to go home and think about it. I want to talk about it with my family. I want to weigh some of the options, and I'll come back and talk later. So it's going to be fairly high touch and fairly repeated interactions with people as they work their way through the process. Implementation of the law, obviously I talked a little bit about what's happening on that front already here in New York, and that's underway. And then there's defense of the law. There are still those who are talking about repealing it, although now I think with the Supreme Court ruling combined with the results of last fall's elections, that's highly unlikely. But they may try to pick it apart somewhat piecemeal. So we kind of have to keep our eye on that. This really is an outdated outline. I really have to update this stuff. 2001 budget resolution. Well, let's skip over that. And other things, and the various court cases and rulings. And then again, I think I just want to challenge us to think, and this is what we've been trying, some of us on the advisory committee have been trying to say to the state, yeah, it's all well and good to go ahead and do what the law mandates that you do and do it as robustly as you can. That's important. But I think we have to kind of have a vision of where do we want to go with this over the long term. Yeah, so we get it in place and we cover maybe hopefully up to 2 million New Yorkers. That still leaves 700,000 New Yorkers without coverage. What are we going to do about them? How do we use this, as I was mentioned earlier, like a state like Vermont is doing? How do we use this creatively so that we can move toward a truly universal program here in New York and make sure that all New Yorkers get comprehensive quality health care that they can afford? And so I think that's really a challenge for us to think about as we implement the law. How can we do it in ways that really lays a foundation so that we can take the next step, continue our long, proud history of being a leader state in New York for other states and for the rest of the nation. So I'll just kind of lay that out as a challenge and stop here. And there's a whole variety of websites here, both from various nonprofit organizations as well as the federal government and the states. Each have got their own websites for information about the Affordable Care Act and what you can find out, what's going on. So I'll stop here and take some questions. I should just mention quickly before I take questions, I got a couple handouts here. Maybe we can, I'll give you one set and you the other set. This is a little bit about the health benefits exchange, sort of how it works and looks like. One piece is a useful little graphic that you can use that kind of simplifies the whole process of using the exchange. And the second piece is some slides from a much longer PowerPoint presentation the state developed for us on the advisory committee. Just a few basic things about the exchange. One thing I'll just mention quickly, because I'm sure it's going to come up in the questions. What are the benefits that people are going to get? So the Affordable Care Act lays out 10 benefit categories that all plans will have to provide coverage for. That's ambulatory care services, emergency services, inpatient hospitalization, maternity and newborn care, mental health and substance abuse treatments, prescription drugs, rehabilitative care, laboratory services, preventive and wellness services, chronic disease management, and pediatric services. And for pediatric, they also include dentistry and vision. So that's what all plans in the exchange, in the small group and individual market, will have to offer those benefits. Now they can vary those benefits a little bit within some parameters, but they will have to offer those benefits. So I just want to kind of point that out for people. So I don't know who wants to, I guess I'll take these questions. I'll start with the lady over there and we'll work our way kind of around this way. Yes?
Okay, a couple questions. One, I didn't hear you mention mental health services.
Yes, it's part of the mandated benefits package. Mental health and substance abuse.
One more question.
Uh-huh.
How do these exchanges operate with the Medicare and the supplemental packages?
Yeah, in the current Medicare program, you can buy supplemental products on the private market to wrap around your Medicare coverage. the exchanges will have nothing to do with that, because that's really operated by the federal government. These exchanges are operated by states. So that's kind of how it will work. That Medicare program will continue as we know. Yep. Here.
Go ahead.
Oh,
Come on.
wait, he's got the mic.
He's got the mic.
Follow the mic, I guess. Help the team.
I'd like to raise the issue of the problem with paying for all health care. The issue that gets short shrift is the way the doctor is paid. There are three main ways that doctors
Hold it straight up to the mic.
There are three main ways that doctors get paid. Fee for service, which is most of the way we do it in this country. Organized organization payments like HIP and other organizations, and doctors working for salary. My background is that I was disappointed in Obamacare that it didn't consider any kind of Medicare, because it was a public option, I think it was called. But I'm all for Obamacare because it's what we have. The background of all healthcare being so expensive in this country, I think gets down to the issue of how the doctor is paid and the way the doctor is paid in this country, mostly fee for service. Fee for service is a system which is very insidious. I'm not saying that doctors consciously do extra procedures, but the number of unnecessary procedures is enormous. It's a scandal that doesn't get enough exposure is unnecessary surgery.
So, excuse me, sir, can I ask you your question, please?
And the question is, in the management of healthcare, and because of the expense, is there any strong direction for changing the way the doctor is paid, especially away from fee for service?
Yeah, there's lots, as I was mentioning earlier, there are very much incentives to move away from this piecemeal fee-for-service system that we've evolved in this country, moving toward bundled payments, payments for episodes of care. Interestingly, just within the profession itself, outside of this act, I think it's approaching almost 50% of physicians in this country are now salaried. So the kind of ideal of the individual private practice fee-for-service thing is really going the way of the dinosaur. We're going to be in a different world in another 10 or 20 years in terms of how healthcare is provided and paid for. It's going to be very different.
My question is more related to medical education and availability of services. If you're putting a lot more people having insurance, there's going to be a lot more people looking for services. So I'm wondering if we actually have the medical infrastructure to handle the increased number of patients. And I'm also wondering if there's a change anticipated in the way in which we will educate medical students for this new situation and these new circumstances, and if part of that will be an incentive to direct medical students or perhaps nurse practitioners away from specialization and into more primary care. Because if they're not interested in it, if there's no monetary incentive, why take on $400,000 of debt?
Yes, there is incentives in here to increase the healthcare workforce, diversify the healthcare workforce, as I was saying earlier, incentivize the training of not just physicians, but also nurse practitioners, physician assistants, and so forth. They're also incentivizing the training of primary care so that there are loan forgiveness programs for people to go into medically underserved areas, particularly inner city areas and rural areas that have less capacity to go there, and particularly if they practice primary care or family medicine or that kind of stuff, pediatrics, to sort of basic stuff as opposed to a specialty. There are loan forgiveness programs that are there. It's all designed to incentivize, to turn our healthcare system much more toward primary preventive community-based services.
Since the beginning of this conversation in Congress about healthcare reform, we as consumers have seen insurance costs, escalate and our co-payments escalate for less coverage. How is this law going to change that? Or are we just are we on that road where we're going to continually see healthcare cost us more for less?
Well, as I was saying before, there are incentives in the system, and again, it's going to, take a bit of time to turn the American battleship, if you will, toward where we have much more robust cost control in the system. We're going to see these savings hopefully accrue, but that will take, again, over a 10-year period. In terms of the actual growth of costs for consumers, the state has this program available, all states now. They have money available to them from the federal government to do what's called rate review. And that is where they review premium increase proposals from insurers annually to see if they're justified.
The metropolitan region is probably 20% or more immigrant.
Yes.
Many of them are legal residents, but legal residents since '96 have had great limits on their access to services. Many of them are undocumented, and many of those are particularly low income.
Right.
Will they be able to access the benefits of the Affordable Care Act? I'm remembering Obama's comment in Congress when he was asked.
Right. And the famous "you lie" got
Yes.
shouted out. Depending on one's perspective, and I'm speaking now for myself as a health advocate, the Affordable Care Act does some things for immigrants, but not a lot, either legal or undocumented. We all wanted the Affordable Care Act to do much more than it does. This is not an unimportant issue for a region like downstate New York. I know in the city, 40% of the population is immigrant. So this is an important issue for people in our region to think about. What are we going to do about those people? So the good news is that under ruling through the New York State courts 10 years ago, the courts ruled that New York State has an obligation under the Constitution to provide health care coverage for immigrants who are lawfully present, who are legal. So we do provide access to our Medicaid program through that. But we do it only with state funding. We are not able to draw down the matching federal dollars for that population because the federal government does not require coverage. Also, for legal immigrants who are here the first 5 years, they are not able under federal law to access benefit programs like Medicaid. That said, we here in New York, as I said, because of the court's ruling, we do offer access to Medicaid for legal immigrants. They don't have to wait the 5-year period. Through our Child Health Plus program, we don't ask about immigrant status for kids at all. So we cover all kids regardless in that program. For and for legal immigrants, they will be able to access coverage through the exchange, although undocumented individuals and families will not be able to use the exchange. And I believe that legal immigrants will have to wait out the 5-year bar to accessing the subsidies if they go into the exchange, although New York, again, could decide to do it if it wanted to. And given the court rulings in the past, I wouldn't all be surprised if, when all is said and done, we end up providing those subsidies to those folks too. And there's some creative ways using this basic health plan approach that I've talked about earlier, this option for states, it's not a requirement, it's an option, that we can provide coverage to immigrant folks, through particularly legal immigrants, through that sort of a plan. And the analysis that the state has done has actually showed that it would save the state a significant amount of money for providing health care for legal immigrant populations, because right now they're doing it with state-only dollars, and if they move to this basic health plan and provide coverage that way, they can draw down federal dollars to do it. So that's kind of the picture on immigrants For undocumented immigrants, nothing much changes. They still have access to emergency Medicaid if they show up in the ER, but once they're discharged, that ends. So we're trying to think about some creative ways that New York can think about providing coverage to those folks through various aspects of the Affordable Care Act, and we'll see what we can do. A couple of questions? All right, we'll kick over to you, sir.
I'm sorry. Here, sorry. Sorry.
I know you haven't mentioned the New York Health Bill, I know you're aware, but do you think that would be a possible way to mesh with the enactment of the Affordable Care Act and use of single payer?
Yeah, what Betsy is asking about is that there is a bill in the state legislature sponsored by Assembly Member Richard Godfrey, who chairs the Health Committee, and I think they've got a Senate sponsor now, right? Is it Gustavo Rivera? Oh no, Bill Perkins. Senator Bill Perkins from Harlem is the Senate sponsor. And it's modeled on what Vermont is trying to do, where they're trying to use the Affordable Care Act as a stepping stone toward true universal coverage for all New Yorkers through a fully public program. Vermont's taking us step by step, and so this bill would sort of set New York on that same path. And I know Betsy's group, Physicians for a National Health Program, Betsy and I both sit on the New York City board of that organization, is working to line up sponsors in both the Assembly and the Senate for that, and to move that along through the legislative process. So thank you for bringing that up, Betsy.
Just on a point of clarification, you mentioned different eligibility levels of 300%, 400% of family income. You said $90,000 for a family is about 400%.
Yeah.
And then when we get to the public insurance programs, Medicare expansion to 133% of poverty level, there's a number a year of $14,000.
Yeah, that's for an individual.
I was going to say that. Can you convert that?
For a family of four, it'd probably be about $45,000, something like that. There is a chart I should bring to these things, which kind of lays out, depending on your family configuration, how many parents, how many kids, what the income level is, et cetera, how that all works.
Yeah, I have a question. In Florida, their Blue Cross is opening up 25 storefronts for information. Is New York not, doing any kind of store for information purposes?
Sure. Yeah. Well, it's not unlikely that as we see this exchange come online, that insurance companies are going to be doing creative things like, for instance, perhaps opening storefronts in communities where people can walk in and get coverage. There will be these new navigators that will be coming as part of the exchange. Those, I don't know if the state has quite put that out. I don't think they put out an announcement or an invitation for people, but nonprofit organizations are welcome to bid for money to become certified as a navigator program and to help people out with these things. There's money available through the state exchange to do that. And probably some plans, health plans, will be doing the same thing. I know brokers are going to be playing a very prominent role, particularly on the small employer side of things, because traditionally small employers have used the broker community to figure out what their health options are and to purchase coverage for their employees. So I know that that's definitely going to be part of the picture. Yes?
How are you handling the great criticism that came, especially during the political debates in the electioneering summer that we had? The way that there is a panel of bureaucrats that sits on top of everything that's going to be answering all our local questions. How do you deal with that particular criticism?
All right, well, let me answer that in two ways. First of all, let me put to death once again the fact that there are no death panels created under the Affordable Care Act. So that's one thing. And that was really something that got blown way out of proportion. What it was a provision to provide funding for physicians and other providers to have conversations with patients and their families about end-of-life care, and to begin thinking and planning about that. There was nothing mandated, and to reimburse providers for providing that service. And that, I think, is kind of an important thing to do, because when we look at, particularly in the context of the Medicare program, where a significant amount of money goes is in the last 2-3 weeks, month of one's life. And some of that can be attributed to the fact that people and families haven't had that conversation. And so,
But that wider,
yeah, the second aspect of this is that there is something for the Medicare program that's called the Independent Payment Advisory Board, which is going to advise Congress on how to control costs within the Medicare program. It's advisory. It is not mandated. However, if Congress, what the board will propose will go into effect unless Congress says no. So it's kind of like Congress does have an oversight role, but it's not like they have to sign off on something. Their role is to stop something if they don't like it. Otherwise, it will go for it. But the board itself, explicitly within the legislation, is not allowed to change benefits within the Medicare program. It's only around payment for those benefits and those sorts of things. So again, that's an issue that's blown way out of proportion. There has been for a number of years a similar kind of weaker version of something that's existed for many years for the Medicare program to advise Congress on controlling costs and also advising Congress sometimes on, the practice of healthcare changes over the years, and so advising them on what's good to pay for, what's not a really valuable benefit. Things change over time. What should be provided, maybe what should be added to the list or taken off the list and so forth. And that's a valuable thing. The Board of Trustees of the Medicare program has this thing that advises them on this stuff, and then they make recommendations to Congress, and Congress decides what they want to do with it. But again, it's just advisory. One more question, and then if people have, questions, they can come up. We'll take 2 minutes, because I know you've had your hand up.
People whose income comes above the subsidized cap,
Right.
but not enough for anything but a high deductible catastrophic plan. Maybe Betsy's question slightly addressed this, but it seems like it's piecemeal. What's going to happen over the next 2 years before an exchange happens? Why aren't we moving in a direction closer to Vermont now to cover that group of people?
Well, I guess a couple of things there. The subsidies and out-of-pocket cost cap will be up to 400% of the poverty level. So that's about $44,000, $45,000 for an individual per year. Family of 4, about $90,000. When you get up to there, the research is really showing that health insurance coverage becomes, relatively speaking, affordable at that point, because you've got enough sort of disposable income to sort of handle that to some degree. So that's one question. In terms of why New York isn't really looking at this more expansive approach to implementation of the Affordable Care Act, moving toward a true universal program, that's something that some of us have been challenging the state to really look at. But I think, given where the administration is right now, and the way our exchange is operating, it's housed within the Department of Health. So the executive branch has a lot of control right now over how it's being designed and so forth. I think they're looking at just sort of doing what the law requires them to do, taking advantage of as many opportunities as they can, but not really going beyond it. That's just their frame of reference. They're making the decision.
So, but you're trying to push that.
Yeah, we're trying to encourage them to really look visionary, like where do you want... Yeah, okay, so we get the full law implemented and it's good and it's working and we're doing all we can and we're taking advantage of everything we can, but what next? How are you thinking about using this for whatever's next? And I don't hear that conversation or discussion about how we're building toward a longer term future. They're just not thinking in that frame of reference. They're just thinking sort of in the next 2 to 3 years, and that's kind of as far as they're going.
Now, there are states that are opting out. Do you want to discuss what that means to those states and why they're opting out?
Yeah, I mean, there's been a lot, particularly since the Supreme Court ruling and the opposition of certain governors and legislatures in states. The Medicaid expansion is now an option for states. Although we're beginning to see Republican governors and Republican states moving to do the expansion, because when you crunch the numbers, it's a really good deal. The federal government for the first 3 years of the expansion is paying for 100% of the cost of that, which is a good deal. Then it scales back to 95% for 2 years and 90% and plateaus off. So you're getting a 90% match. Now, for us here in New York, because we're already covering a lot of these people, we're not seeing much of a change. But for Texas, that Medicaid program only goes up to 25% of the federal poverty level for a parent. So if you make more than $3,000 or $4,000 a year, you're out of luck. They're moving this up. They're getting 100% for that huge amount of people. So, although the Texas governor and legislature has said they're not going to do the expansion yet, we'll see. Arizona has moved. Some of the Michigan and Ohio have now decided. And there's one other Republican governor state that's since decided. So, New Mexico. So I think they're going to start to see the handwriting on the wall, particularly because the federal government money that comes to states to provide for uncompensated care is going to start scaling back under the Affordable Care Act on the presumption that people are getting coverage. So states are going to have less money to play around with for their uncompensated care. So I think they're going to say, we're going to do the Medicaid expansion. A similar thing happened when the Medicaid program itself was first enacted. It took 10 years or more before all states really signed on to the Medicaid program. So it'll happen. It's probably just a matter of time.
My question surrounds reproductive health care.
Sure.
It was announced by Sebelius last year that reproductive health care would be considered preventive.
Yes.
But there's a lot of kickback. What do you envision is going to end up happening?
Well, the federal government has determined that contraception in particular is considered a preventive women's health service. And so there have been some pushback from certain quarters with regard to that decision. And there's been an opt-out that's allowed for religious organizations, such as churches and so forth, that may have an objection to providing contraception coverage for their employees. However, they did not extend that to religiously affiliated institutions like universities and hospitals and so on. So there's some pushback from those quarters, and there's some court cases that are moving through similar kind of things for employers who are motivated by religious reasons to say that they don't want to, because of their own religious beliefs, they don't want to provide this comprehensive reproductive health care services to their employees through an employer-sponsored plan that they may offer. The federal government has determined that it has to offer in the plan the full comprehensive range of reproductive health care services, including contraception, but not limited to contraception. So there's some pushback in those quarters, and there's some court cases that are moving along, but we'll see how they play out. So far, the administration is standing fairly strong on that.
We should all read Bill Keller yesterday about that.
Okay, yeah, there was an op-ed piece in the New York Times yesterday about it. One last thing I'll just mention, there's a couple of really interesting and useful pieces from our friends at Consumers Union that's about the Affordable Care Act. It's really designed for just the average Joe public person who knows little or nothing about the Affordable Care Act. And so please pick one up, including all of us probably, to help you understand things and sort of basic things that, the language that we all talk on a regular basis. So thank you very much.
Thank you, Mark.
Thank you, and thank you all for coming. It was very clear.